Someone mentioned this earlier. It's a tough area because we're dealing with the brain, and in actuality, all of the body parts are linked to the brain and its function, the vertebrae. So there are certain elements that we have to look at when we talk about, we got to look at almost everything when we talk about neuro. So what you see here is I put this together myself, because see, I'm a visual learner too. And this is a care map, if you will, of someone who's a brain patient here, and then a spinal cord injury. And so it looks at diagnostics, it looks at the precipitating factors, complications, and it looks at all of those entities that are important in caring for someone who may have a brain injury or a spinal cord injury. So it is one of the toughest areas. But this is kind of nice to go back in review, all right? Factors affecting cerebral blood flow, we call that the CBL. Factors that affect the cerebral, and that's what we're talking about. We're talking about the blood flow in the brain, okay, and throughout the body. So you gotta look at your oxygen, you gotta look at your carbon dioxide, and your hydrogen ion. Those three are a reflection of the cerebral blood flow. And after cerebral blood flow vessel tone, in effect, partial, so we've got to look at your CO2, your PaCO2, and then here's the true element here for this particular slide. When the PaCO2 is elevated, this is what's happening. You've got to dilate the cerebral vessels, a decrease in cerebral vascular resistance, and an increase in your CBL. If the PaCO2 is decreased, then it's going to be the opposite of that. So that's the learning with this particular slide. Other than that, you got to go back to and look at the book. Okay? So for this particular slide, this is what I'm saying to pay attention to. And understand that these three factors are a reflection of that CBL. Okay? Now, factors affecting it, again, cardio or respiratory. So when I say that elements of when we talk about neuro, these all play a part systemically, they do. Other pathophysiological states, diabetic coma, we talked about that earlier when we talked about diabetes, that's serious. Encephalopathies, infections, toxicities, those are serious disease or conditions that can affect that cerebral blood flow, okay? And then when you add on regional aspects like tumors or trauma or stroke, it becomes even more involved. So, mechanisms of increased ICP. What is ICP? There are a number of patients who become unconscious, and we don't even know why. Sometimes they're brought to the hospital that way. But an increase in ICP is a clinical significance, okay? And so it can diminish the CPP, and it's ischemic related. So these are some elements that can cause the ICP to increase, your intracranial pressure, all right? I'm thinking. I was gonna say something, I lost my train of thought. Okay, we'll get it come back. Methods of ICP and cerebral oxygenation. Now, this is important. If I say that, that means you might want to pay attention. Usually, to monitor the ICP in ICU, the usual monitoring method, the gold standard, is your ventriculostomy, this lateral ventricular. So that's like in here. And let me show you a picture of how that's done. Actually, I have it from my mentor too, students as well. You see all this stuff? If you ever see this jump drive, this green one left somewhere, if I leave it, please collect it and give it back to me. It's my light. It's my lifeline.
Put it on a cloud.
Put it on a what? Oh, a cloud?
Yeah.
Yeah, you can have it everywhere.
It's Google Drive, so you don't need it.
But I have to have access to the cloud.
You have access to the internet, you have access to the cloud.
I don't know, I'm scared to do that, guys. I'm afraid everybody in the universe will have it.
We don't want that.
Okay, here. So, intracranial pressure monitoring. What is that? I just want to show you how that would be done. Word will not convert. It won't open it up for me? Oh, there it is. Okay, so you see, this is kind of the process for monitoring. So the patient is going to be, 9 times out of 10, they're going to be sedated. Patients, many patients, neuro patients, are intentionally sedated to keep the ICP from increasing, because they don't want them thrashing about and causing that. There's different ways to increase that. But this is the monitoring process. As you can see, it goes into the skull. And so this is a 3-way stop. So we're monitoring, and it's giving us printouts. I just thought I'd show you that visual. Okay, so the transducer must be leveled. As you could have seen in that picture, it has to be leveled appropriately for appropriate results. 2 options for ICP drainage is intermittent or continuous. It can be intermittent or continuous monitoring. Drug therapy for ICP. The main one, these are drugs that are used to monitor patients who are on ICP. The number one you see says mannitol. That is a diuretic. What's that?
Osmotic.
It's osmotic. It's a diuretic that is primarily used for patients who are, that are trauma type patients. And when they're trying to decrease the ICP, it's kind of the drug of choice, okay? Hypertonic saline, they will use. Corticosteroids. Why are we using corticosteroids? For the inflammation. And what do you as the nurse have to monitor if your patient's on corticosteroids? Glucose, the blood glucose. Not that they're necessarily diabetic, but because they're on the steroids. So, the metabolic demands of the body can cause any of these: shivering, agitation, seizures. And so we have to monitor metabolically for these patients. And in many cases, like I say, they sedate them to keep these kind of things from happening. So the MD will order the rate that they want to achieve in terms of monitoring, and so the nurse will follow that, okay, based on what the order says. So you've got to check your orders. It's just like in skills. You guys have started skills, correct? No?
Yes, we did in the spring.
Oh, you did in the spring?
Yes.
And what's the number one thing you have to do before you act?
Assess. Hand hygiene and assess.
Well, I should be a little bit more specific. You are right about hand hygiene. But you've got to check the doctor's order. You do nothing unless you check the doctor's order to understand what parameters might be or specifics, okay? That's what I meant by that. You need to know the Glasgow Coma Scale. And the three elements that relate to that are the three indicators. We're gonna look at the eyes, the verbal response, and the motor response. Three indicators for the Glasgow Coma, because that's gonna give us an assessment information about the patient as well. What is it? How severe is the coma? I'm sorry, I missed that. Yeah, there are specific numbers and that you follow for all three of these indicators in terms of where the patient falls in. Yes, that's what you're saying. So, look that up in the book, Glasgow Coma Scale. We want to make sure there's adequate circulation and respiration are the most vital functions to assess. When a patient is in a coma, or they are a trauma patient, or the neuro patient, you want to make sure that they're, so what are we talking about? ABCs. Adequate circulation and respiration are going to be your ABCs. So you've got to make sure that you're checking, and then vital signs. So I'm not trying to complicate this, as neuro can be challenging. I want to kind of, again, like with the diabetes, give you what I think is important for you to know, okay? Now, if you need much more information in reference to what I'm giving you, go back to the book and reference the book, okay? Now, when we say a neurological assessment, these are some of the first was here, ABCs. Now, so when you're doing a neuro assessment, you want to look at these entities as well, right? Because they're going to give us some information about where that person is with the problem. So what's the PERLA?
People's reaction to
And accommodation.
That is correct. So you should check that, okay? Then we want to look at oculomotor nerve. Now, I don't know, I'm not gonna test you specifically on all of the central nerves. Do you know all of the nerves? That's AP. You should have learned that in anatomy and physiology. But know that the oculomotor nerve is your CN3, okay? Ocular motor is going to be your CN3. If the ICP continues to increase, guess what's going to happen? The pupils will dilate. That's why it's important for you to do the PERLA. So you can see if there is a dilation of the pupils, which will tell you that ICP is elevated. Okay? Fixed pupils, unresponsive to light, usually indicates an increase in ICP as well. So that's why you have to know the oculomotor nerve, and you want to check these things. Because that patient's not going to say anything, but what you're doing is assessing their pupils, and that's going to say a lot. Okay? Motor strength. Squeeze their hands. ask if they're able to squeeze your hands, that's good, but if they're not, you can use other cues to try to understand their strength. You can push down, you can push their legs or try to get some idea about what is their strength level, okay? Assess your vital signs. And then Cushing's triad means that's a severely increase in ICP. I'm gonna show you what that is in a minute. And then suction as needed, less than 10 seconds. Some of these neuro patients may require, in an ABC sense, they may require suctioning. How many times, if you're suctioning, should you go down? 3 is the max. And you should not be down there when you go down, not very long. How long? We say less than or up to 10 seconds each time, okay? Because let me say this to you, suctioning is traumatic. And the patient probably requires suctioning, right? In an ABC sense, but it's kind of a catch-22 because your suctioning can cause the ICP to go up as well. I'm making sense? Yeah, so you gotta do that very, very carefully. We want to prevent hypoxia and hypercapnia. What's hypercapnia? CO2, increase in CO2. Now, you've gotta read the doctor's order, but at least, if it doesn't say, you want to position the head of the bed at 30 degrees. The book may have said, it may have said 60. In some cases, it could be for a trauma type patient, a neuro patient. Okay? It says 30? Okay, thank you. And then, they may require some medications, I listed some here, in terms of neuromuscular, a blocking agent, just to keep them stable. We want to avoid benzodiazepines. What's an example of that? Benzo, that is one, yeah. Hypotension effect and long half-life, so they can have problems, they can be problems for the patient. Monitor ABGs. What's ABGs? What falls in an ABG? What are the elements?
CO2, bicarbonate,
pH. Yes. So, there will not be, I'm not gonna give you any questions on ABGs, on this fourth exam. But you could have, questions from HESI and NCLEX, all right? Whenever I say, I'm not going to test you on something, that doesn't mean you forget about it. Because you could see it on HESI or NCLEX, it's just that I'm not gonna test you on it, okay? Closely monitor IV fluids, because what are we concerned about? Fluid overload. Fluid overload. And if you have a neuro patient, they should be on INOs. There are certain types of patients that should be on intake and output. You need to know what's going in and what's coming out, because we want to know that there's a balance. And in some cases, if we can, daily weights. Now, if it's a neuro patient, you're probably going to be using the bed scale. You're not going to be trying to stand them up and weigh them. You use the bed scale. Same time, same way, all the time. Now, I mentioned Cushing's triad. Here's what that means. 3 primary signs that often indicate an increase in ICP. They're very consistent. Systolic BP an increase in your pulse, and a decrease in respirations. These are considered triads. They go together. And if a patient has all three of these at the same time, that's serious. They're probably experiencing an increase in ICP. So if you look at the ICP, it's probably gonna be elevated. If you see these three, you with me? Increase in your systolic blood pressure, decrease in pulse, and decrease in respiration. Now, at the same token, if the patient is experiencing shock, it's the opposite of those. You see here? So it's gonna be the opposite if they are experiencing shock. So if you know, here's what I'm trying to get you to learn. Learn one of these. Because if you know one set, you'll know the other when you see it. All right? Because it's gonna be the opposite. Discerebrit and decorticate. Discerebrit or sometimes on assessment you might see these. But we gotta remember I said labs. You gotta monitor your labs. Electrolytes, your sodium, potassium, magnesium, osmolality. Monitor for SIADH. Monitor the ICP. We want to turn the patients, they have to be turned when they're in ICU, but you turn them slowly and gently, because we do not want to increase the ICP when we're turning them. So it's probably going to take 2 or 3 people to do that. You may have to log roll them, and that's why I'm saying 2 or 3 people. Decorticate, you do have to know the difference between decorticate and discerebrit. There are postures that sometimes our neuro patients might be in. Now, the way that I teach to try to remember is discerebrit is going to be the arms are down. Decorticate with this, well, they both have the C's in it, but decorticate is going to be, they're going to be up like this. And if you learn one, you know the other. So decorticate, discerebrit, okay? Where the body is rigid. I was trying to see if there was a way to just help you learn the difference. Yeah, I was just looking at that. COR is decorticate, so that's going to be like this. This cerebrit is going to be extensions of your arms are down. So kind of think of it that way. I'm going to give you, I'm just going to tell you, I'm going to have it on the test. So, yes ma'am. I've never seen that. Because that would mean the brain is confused and it's not distinguishing. I don't, usually it's one or the other. But that's a good question, yes. I'm sorry, I can't hear you. You experienced that? You got to see it. And it was both?
It was both, but one was much more
Prominent than the other?
we couldn't fit it all.
See, I would be concerned about whether it's both of them at the same time, or is it a contraction? But you guys saw both? Yeah. Were you in clinical? Yeah. Yeah, that's good experience. Not for the patient, but, okay. So make sure you know, the difference. And then what we do is, like I said, sometimes to protect the patient, we will sedate them, and they may put them on like Ativan or Versed. Provide support, education, and information, particularly for the family. Because remember, it's not just the patient's problem, it's the family's problem as well. So you've got to be, as the nurse, the advocator for both the patient and the family. Okay? Spinal cord injury. Yes, that will be on the exam. Now, know that the edema can be above or below the injury, and there can be ischemic damage. So, neurological damage caused by spinal cord injury result from primary injury, or it could be secondary. So that's what I want you to know. The injury can be primary or secondary. Secondary injury progresses over time. In terms of the difference, primary is going to happen quickly. Secondary develops over time. To understand the difference there, okay? And what we're looking at in terms of damage, ischemia, hypoxia, hemorrhage perhaps, and edema. 50% of people with acute spinal cord injury experience a temporary neurological syndrome, spinal shock. Spinal shock. It's temporary though. Let's see. Decrease in cardiac output, okay? And you have venous pooling and a decrease in cardiac output. Classified by mechanism of injury, skeletal and neurological level of injury. So it depends on where that injury occurs, all right? Major mechanisms of injury could be flexion, hyperextension. So it could be any of, we just talked about the cortic and the cerebral. So it could be a reflection of those as well, okay? Level of injury, skeletal level equals the vertebral level. Most damage to vertebral bones and ligaments. So the level of injury may be, this is what I want you to know here, cervical, thoracic, lumbar. So it could be a combination thereof, or it could be primary, one of these. Cervical and lumbar are most common. Cervical and lumbar are most common. And with cervical, you're gonna have paralysis of all four extremities. That's what we call tetraplegia. Thoracic and lumbar are paraplegic. Paralysis and loss of sensation in the legs, just the legs. So know the difference between those two, the cervical and then the thoracic and lumbar. Cervical is going to be all four.
Dr. Callahan.
Yes.
So I'm noticing that the spinal cord injury stuff shows up in chapter 60 of the book, and that's not listed in the syllabus, so I'm wondering if...
Let me look. Let me go back. It's not on the calendar?
No, I just didn't know if maybe there's like a section of another chapter that has the spinal cord information, or if it, or if we should just get the information from the PowerPoint only.
No, let me see. I teach masters too as well, so I might be confusing. Okay, so where are we here? Oh, so it says 60?
Yeah, chapter 60 is spinal cord and peripheral nerve problems.
Okay, so you don't want that then.
Okay.
We don't want that. What's 61? Oh, I got my book, never mind.
Assessment of musculoskeletal.
Okay. Yeah, that's the musculoskeletal. So when I look at neuro, I'm looking at 55. So the intracranial problems, we talked about that.
Yeah.
56, 57 is stroke. So that's where 56 is, that's 55 is your assessment of the nervous system. So I'm not gonna go through that because that to me is A and P. So I think, in 56 we just covered. So 57, I need to do 57 and 58.
Well, on the last slide, you had up slide number 14, it actually says under the major mechanisms of injury, it says see figure 61-5. She goes back to her slide in PowerPoint.
Oh, okay. 61-5.
Yeah, it says see figure 61-5.
Could be chapter 16.
See if that's.
Okay. Thank you.
What is
So
that
go
do?
back to slide number 14.
Go back to 14?
You see
Oh, yeah.
see figure 61.
Yeah, but figure 61-5 is muscle, it doesn't have any.
That's muscular, yeah.
It's just a.
Okay.
Muscle.
All right, not to worry, guys, hang on. 57, 58, so stroke and then chronic neurologic problems. I wonder if that is, let me look at 58. Maybe I'm jumping the gun and giving you mid-search 2 stuff. Because what happens is, I just did neuro for them, but I had a different PowerPoint. Okay, so I should be doing, 50, 57 and 58. So let me skip to that. So, let me preface the point that don't worry about, let me see. Okay. Don't worry about 13 through, let me see, what is spinal cord injury? Okay, so we're gonna take out from this PowerPoint, I'm going to take out, what did I say? 13. All of the spinal cord.
So, I found some spinal cord stuff in 63, but it's like spine, low back pain, things like that. If you want to look on page 606.
So no spinal cord injury. And that's going to be 14 through through 22.
Thank you.
I'm not done yet. Okay, 23, let me go through it now. 23, yes. 14 to 22, no. 24 through,
The
24 to 29, no. You writing?
Yes.
I'll go back and put them on that first slide as well.
Thank you.
Now, so you do have to know about headaches. So let's look at, you have to know about seizures. All of that, all of the seizure information slides you have to know.
You said yes to
I said what?
Can you repeat all the no's?
I said yes for 23, the neurogenic bladder, because that's related to the,
Oh, that's 22.
We all know all the
I said
No, 13 to 20.
14 to 22, no. 14 to 22, no. 23, yes. 24 to 29, no. Unfortunately, I gotta leave all this seizure stuff in. I gotta leave the stroke stuff in. Your CVA, that's your stroke, I gotta leave that stuff in. I'm sorry, guys, I should have put together a different slide for you. A different PowerPoint. So we're gonna have to do,
We take a break.
yes, take a break.